Hello everyone, my name is Marci Santos. I'm a clinical application specialist working in Hamilton Medical, and I would like to share with you a novel non-invasive method to detect excessively high respiratory effort and dynamic transpulmonary driving pressure during mechanical ventilation. This was an article published in 2019 in Critical Care, and the authors hypothesized that the swing in airway pressure generated by the respiratory muscle effort and the assisted ventilation when the airway is briefly occluded could be used as a non-invasive technique to screen for conditions of high respiratory effort and detect high transpulmonary driving pressure. What's the rationale behind it? We know that patient inspiratory effort during mechanical ventilation may have both beneficial and deleterious effects. Inspiratory effort might increase tidal volume and indeed increase the risk of volute trauma and global stress. Vigorous efforts generate pendulift and amplify regional lung stress and strain, causing regional lung injury and therefore patient self-inflicted lung injury. The amplitude of this regional stress is reflected by the dynamic transpulmonary driving pressure, and so it deserves special and close attention during mechanical ventilation. Spontaneous effort may have different impact on the non-dependent or on the dependent lung. Plateau transpulmonary pressure corresponds to the time of maximal distension on the non-dependent lung, but this is not always a good surrogate for the dependent lung stress. When the peak transpulmonary pressure occurs at the time that the esophageal pressure is most negative as a result of a vigorous effort, we see that the dynamic transpulmonary pressure corresponds to the point of maximal distension in the dependent lung, and this region is at most risk during spontaneous effort. So we can potentially underestimate the maximum lung stress by only assessing plateau transpulmonary pressure. Why do we monitor spontaneous breathing in ARDS patients? Respiratory muscle pressure can be assessed with some techniques available: esophageal manometry, diaphragm electrical activity, diaphragm ultrasound. However, in practice, it might be difficult for the clinicians to assess it on a daily basis because they need adequate equipment for that and to invest some time over it. PO1, which is the drop in airway pressure during the first 100 milliseconds of an inspiratory effort, is quite simple to monitor and it's widely available on the ventilators. However, it doesn't show us the magnitude of the dynamic lung stress generated by the combined effect of the ventilator and the patient's respiratory effort. So what if we could do and have something who could substantially increase the feasibility of detecting injurious spontaneous breathing during mechanical ventilation? The hypotheses of this study were, first, that during an inspiratory airway occlusion, the airway pressure deflection generated by the patient's respiratory effort against the occluded airway correlates with the pressure generated by the respiratory muscles to expand the lungs and chest wall during mechanically assisted breaths. And second, that the excessive patient inspiratory effort and the excessive dynamic lung stress could be rapidly detected non-invasively by measuring the change in occlusion pressure. Methods. So they conducted this study in 2 medical surgical ICUs in the University Health Network, Toronto, Canada, whose findings were used as an ancillary analysis on another ongoing study called myotrauma. Patients were included if they were intubated less than 36 hours for acute burn injury, ARDS, septic shock, or pneumonia, and were excluded if they were unlikely to remain ventilated for at least 7 days, having contraindication for an esophageal catheter, or having an acute exacerbation of the obstructive lung disease. They have used a nasogastric catheter with an esophageal and gastric balloon, plus a diaphragm monitoring, AMG. Patient inspiratory effort were monitored continuously for up to 7 days or until extubation or death, what comes earlier. and they applied 15 to 20 end-expiratory airway occlusions lasting for the duration of a single inspiratory cycle intermittently over a 10-minute period, and they recorded flow, pressure, esophageal pressure, and eddy during the 10 minutes period. So flow, airway pressure, esophageal pressure, and diaphragm electrical activity were recorded, while an end-expiratory occlusion was applied. The transpulmonary pressure was measured by real-time digital subtraction of esophageal pressure from airway pressure. The dynamic transpulmonary driving pressure was quantified as the increase of transpulmonary pressure from the onset to the peak during inspiration on each breath. Chest wall elastic recoil pressure was computed by multiplying tidal volume by predicted chest wall elastance, which empirically estimated based on vital capacity. Inspiratory effort was quantified by the peak inspiratory muscle pressure, computed as the difference between the chest wall recoil peak pressure and esophageal peak pressure. Pmus was computed as the sum of the PTP of the chest wall and the PTP of the esophageal pressure, which is the area comprehended on this graphic. So while doing this, and to avoid measurement errors due to inaccurate esophageal pressure measurements, they excluded records where the ratio between the airway pressure and esophageal pressure was outside the 20% tolerance. Threshold values for excessive Pmus and dynamic transpulmonary driving pressure were decided given several physiological and clinical considerations based on previous study. Pmus normal ranges between 4 and 10 centimeters of water. Transpulmonary driving pressure normally ranges between 4 and 8, and therefore that might be considered as excessive values, a Pmus between 10 and 15, and a dynamic transpulmonary driving pressure between 15 and 20 centimeters of water. For the statistical analysis, the goal was to determine whether the change in occlusion airway pressure could be used to first predict average values of dynamic transpulmonary driving pressure and Pmus for assisted breaths, and to detect whether these values and these cutoffs were exceeded. So they had two cohorts on this study, one internal and one external, where they compared the values directly measured in one cohort with the predicted ones after validations. They end up with the following equations to predict Pmus and dynamic transpulmonary driving pressures. After excluding 30 recordings because the ratio between the airway pressure and the esophageal pressure was greater than the 20% tolerance, a total of 52 daily records were available in 16 subjects. So 12 patients were available in the external validation cohort, and patient characteristics in both cohorts are summarized in this table. Most of the patients in both cohorts were admitted for pneumonia rather for the other cause. And we can see, for instance, then on the internal validation group, the primary cohort, we have lower airway pressure than on the external group, having higher levels of Pmus. But despite that, the dynamic transpulmonary driving pressure was actually very similar on both and presenting in any case excessive levels. This is the distribution of the dynamic transpulmonary driving pressure and Pmus during mechanical ventilation. And we can see that the Pmus exceeded 10 centimeters of water in 84% of the patient days of the study and exceeded 15 centimeters of water in 53% of the patient days. And at least in one study day, the Pmus exceeded 10 centimeters of water for 88% of the patients. The Pmus was higher under partially assisted modes, as well it was higher in patients admitted for pneumonia compared to patients with non-pulmonary admission diagnosis. The dynamic transpulmonary driving pressure exceeded 15 centimeters of water in 69% of the patient days and exceeded 20 centimeters of water in 40% of the patient days. And in 81% of the patients, the dynamic transpulmonary pressure exceeded 15 centimeters of water at least in one study day. So actually, the Pmus and the dynamic transpulmonary driving pressure were both within ideal limits on only 8% of the patient days. Airway peak pressure and airway driving pressure were always kept under the desired thresholds. Meanwhile, the dynamic transpulmonary pressure was most of the time above the safe thresholds, meaning that while the peak airway pressure and airway driving pressure were okay, there was a harmful ventilation going on independently of the mode because it was not different between the partially assisted mode or the controlled one. For the validity of the change in airway occlusion pressure, it was important to see that there was no difference in peak eddy between the occluded and the non-occluded breaths, which was confirming that the respiratory drive was unaffected by the airway occlusions. As a result, first, the agreement between the predicted and the measured values of Pmus and the dynamic transpulmonary driving pressure in the internal validation cohorts were unfortunately marginally acceptable, so they could not use the predicted values to assess the real ones. However, the predicted values accurately detected excessive Pmus and dynamic transpulmonary driving pressure thresholds. So for a real Pmus above 15 centimeters of water, we have the cutoff values of predicted Pmus of 15 centimeters of water that shows a good specificity and high sensitivity. And for a real dynamic transpulmonary driving pressure more than 15, we have the cutoff values of predicted 15-17 with a high sensitivity. It was demonstrated that the measurement of the change in airway occlusion pressure from 3 randomly applied and expiratory occlusion maneuvers can detect excessive Pmus and dynamic transpulmonary driving pressure with high sensitivity and specificity, even though the agreement between the predicted and the measurement values were not sufficiently reliable. In spontaneous breathing patients under mechanical ventilation, inspiratory effort and dynamic lung stress frequently exceed safe thresholds, irrespective of the depth of sedation or mode of ventilation. So patients rarely exhibited the ideal combination of lung and diaphragm protective ventilation parameters. The magnitude of dynamic lung stress during spontaneous breathing was often seriously underestimated by airway pressures available on the ventilator, confirming that the airway pressures on the ventilator are an unreliable marker of dynamic lung stress when patients are spontaneously breathing. Some limitations of this study. First, as there weren't performed any inspiratory holds, the dynamic transpulmonary driving pressure is measured in this study, representing a dynamic measurement that may overestimate the actual mechanical stress applied to the lung. But peak transpulmonary driving pressure is reached at the time point when the dependent lung maximally distended by vigorous spontaneous efforts. So that's the region most of risk during spontaneous breathing, and it may therefore to be clinical relevant marker of dynamic lung stress in this context. Second, the Pmus measurements require measurement of elastic chest wall recoil pressure. Owing to the absence of recordings of passive ventilation in most subjects, they relied on empirical estimates of chest wall elastance derived from predicted lung volumes. And third, the number of patients in the primary dataset is relatively small, possibly limiting the generalization of the findings. So maybe we have a new tool at the bedside. This is the proposed algorithm for monitoring respiratory muscle pressure and dynamic transpulmonary pressure swings directly from the ventilator waveforms and without further advanced monitoring. By doing regular and expiratory occlusions during spontaneous breathing, it's possible to measure the negative deflection in airway pressure. Then applying the suggested formulas, we get the predicted values for respiratory muscle pressure and dynamic transpulmonary driving pressure. In case those predicted values are excessive, meaning Pmus above 13-15 or dynamic transpulmonary driving pressure above 16-17, it should alert the clinician that the patient is going under injurious mechanical ventilation, and on this case should be considered either advanced monitoring like esophageal pressure measurement to guide clinical management, or modify sedation and ventilation to achieve acceptable limits. As a conclusion, inspiratory effort and dynamic lung stress often exceeded safe limits in patients breathing spontaneously under mechanical ventilation. Pmus and dynamic transpulmonary driving pressure values predicted from the airway change in occlusion pressure are not sufficiently accurate to replace direct clinical monitoring, but these measurements can be used to detect excessive inspiratory effort and dynamic lung stress. Measurement of change in airway occlusion pressure is an easy, rapid, non-invasive, and well-tolerated maneuver that could be used routinely at the bedside to continuously assess whether the spontaneous breathing is below safe thresholds. Thank you for your attention.